going on here. Welcome. I'm glad you're here. I appreciate your time. I'm here to talk to you today about how to use evidence-based registries to identify interventions that are aimed at reducing substance use among youth. And in going through these slides, I do want to give a shout out and a special thanks to my colleague, Dr. Carl Hill from the University of Colorado. He's also on the advisory board for Blueprints for Healthy Youth Development, which I'm involved in running, and many of these slides he helped develop. So just to start, we will go for, I think, Patty, correct me if I'm wrong, about an hour, and then we'll have question answers at the end.
Yes.
And so you can insert your questions. I won't see them, but my friends at ADAPT will be monitoring them, and so we'll be sure to save some time at the end to make sure we get your questions asked. And then also they have my contact information, so you can follow up if you want additional information. So quickly, what are we going to accomplish here today? Well, first of all, we're going to talk about what are evidence-based registries. Another term used for evidence-based registries is also called online clearinghouses. We're also going to give an overview of evidence-based interventions that are housed within these online clearinghouses. And then I'm going to talk briefly on what we call the evidence continuum. I heard Laura mention that briefly in her intro in terms of the kinds of webinars you might have received in the past. And today's focus is really going to be, when we think about that evidence continuum, really highlighting that piece that identifies interventions that, quote, work. And then we will go through some online registries of effective interventions, but I really today am going to focus on Blueprints for Healthy Youth Development. I'm going to show you how to navigate and collect information provided by Blueprints. And then we're going to wrap up with the discussion about best practices for how to adapt evidence-based interventions to fit local needs, because we are all working in diverse communities with individuals who have diverse needs, and there is no one size fits all. The objectives today, and this was included in the advertisement for the webinar, we're going to discuss the rationale and function of online registries. I'm going to describe how the Blueprints registry in particular determines effectiveness based on the best available research evidence. We're going to demonstrate, I'm going to show you a demonstration of how to locate evidence-based interventions within the Blueprints registry, how to identify interventions that fit the needs of your community, how to conduct those searches within the registry, and then reviewing key considerations to support implementation of certified interventions, such as how much do those interventions cost? What kind of guidance is provided in terms of how to implement with fidelity? And then how do you balance adaptation with fidelity to those core components? I often get the question, who do we serve? And at Blueprints and other online registries, we really do consider multiple stakeholder perspectives, one of which being individuals from the community, who might ask the question, how can we effectively address youth drug use, violence, and related outcomes? How do we help our children thrive? There's also questions posed by folks like you who make decisions about what interventions or what services to provide families you're serving, or policymakers who are making legislative or budget decisions, asking questions about how can we know that we are funding and implementing the most effective programs for our communities, really focused on how do we not waste taxpayer dollars. And finally, individuals like myself, researchers, and our perspective being, how can we ensure that our intervention is producing the most positive impact for each community who elects to adopt it? So the clearinghouse community represents all these different stakeholder perspectives in trying to meet the needs of multiple groups. And the role of online clearinghouses, or the function, is to assess applied evaluation studies of interventions according to evidence standards and identify effective interventions. The focus of the work and the research synthesis conducted by online clearinghouses is to identify results from high quality research to answer the question, what works? And from this work, we then generate an inventory of evidence-based interventions. Well, what exactly is an evidence-based intervention? EBIs are interventions that have been rigorously tested, proven effective, and translated into models available to community-based organizations. And these evaluations, the evidence used to identify the effectiveness of these interventions, have been subjected to critical peer review by experts in the field, not just the people who have developed and evaluated the program. But these experts have examined the evaluation's methods and agreed with the conclusions of the intervention's effects. Why invest in evidence-based interventions? What are the advantages? Well, first, there are many. One is EBIs are more likely to positively impact the health of participants. Funders are increasingly expecting programming to be based on solid research evidence. Program directors want to concentrate limited resources on proven effective strategies. Managers can concentrate efforts on delivery rather than development, allowing more time to reach a larger population and, importantly, have a great impact. And when you think about it, EBIs with demonstrated outcomes can actually facilitate community buy-in and the formation of strategic partnerships. So I'm now going to pivot to the discussion of blueprints and how we can meet many of these community needs. So Blueprints is a web-based registry of experimentally proven programs promoting the most rigorous scientific standard and review process for certification. At the bottom of this slide is our URL. So what do we do at Blueprints? Briefly, an overview of our work. At Blueprints, we identify and review studies and reports that test effects, and by that I mean changes caused by an intervention, of a program or intervention, and by that I mean the activity, policy, or practice intended to produce effects on positive youth development. We then summarize our conclusions for policymakers, practitioners, and others who seek to make evidence-based decisions. So what exactly makes a program, practice, or policy evidence-based? There is a lot of noise out there that can cause a lot of confusion, a lot of terminology that's hard to dissect what we mean by evidence. So I'm now going to spend some time in these next slides talking about how do we define the term evidence-based. Because as I just previously mentioned in the last slide alluded to, there is a lot of confusion around this term. So I would like you to think about evidence as following on a continuum. And this is an example of some of the different terminology out there for evidence. But thinking about this continuum, the higher that evidence falls on this evidence continuum, the more confident you can be in what the conclusions are based on that evidence. And when it comes to understanding evidence, there are actually two dimensions. One being evidence occurs in stages. And secondly, there are different types of evidence. So first, I'm going to talk about what we mean by stages of evidence. So think about evidence takes time to generate. It doesn't just happen. And there are stages of this work. The first being we'll build evidence that's more anecdotal. Could be that someone has a really good idea. Evidence is then formed from focus groups, surveys, or opinions and people's experience. So that's anecdotal evidence. And then over time, you build, develop your interventions, develop your programs, develop your strategies, start to test them out using correlational strategies. And that's evidence of reliable relationships between variables. And then the highest level of evidence it takes the most time to generate would be evidence that you can then make causal statements from. And by causal, I mean evidence that changes in one variable can be directly attributed to another. So we talked about stages of evidence, and now there's different types. So think about evidence as similar to a Venn diagram. So you're going to make a decision using evidence, and it's going to be, this decision is going to be driven by many factors. One of it, which being what we've just spent some time talking about, the best available research evidence available for that type of strategy. And again, there are different stages from anecdotal to correlational to causal. So that's one factor in our Venn diagram. Another is what we call experiential evidence, and that's where you come in. This is your professional insight, your understanding of research, your skills, and your expertise that is accumulated over time when it comes to making a decision generated by evidence. And then we can't ignore contextual evidence. And that is whether the strategy is useful, feasible to implement, and acceptable by a particular community. So there's a lot going into making these evidence-based decisions. And when we think about the role of online clearinghouses and the role that Blueprint serves, and that's what I'm going to spend most of the rest of the conversation around today, we really do focus on this causal evidence. So what does it take to make causal inferences, to make decisions that something works? There are two types of research designs that are necessary in order to make causal inferences. One is called a randomized control trial, and one is called a quasi-experimental design. And these are the types of research designs at Blueprints that we are frequently or constantly reviewing. So what is the difference between an RCT and a QED? So the main difference is that group assignment for an RCT, so those who either get the program versus those who don't get the program, is random. As compared to a quasi-experimental design, in which group assignment to treatment, those who get the program, versus control, those who don't, is not random. There are also non-group designs. This would go in the stage of evidence called correlational, where we've got a pre-test and a post-test, but you're not comparing them to another group. That's an example of a pre-post design. These are really important in designs in terms of building evidence, but they are not the type of designs that are reviewed by Blueprints, because they're not the type of designs that you can generate causal inferences from. Let me explain to you briefly what I mean by group assignment in an RCT that is random. In random assignment, a random process is used to assign units to groups. This could be a coin toss, a random number generator. There's lots of ways to randomly assign. And the units can include individuals. So in the case of educational outcomes, you've got students that you could be assigning to receive the program or not. You've got teachers. Those are individuals that can be randomly assigned to receive the program or not. You also have what's called a cluster randomized controlled trial, and that's where clusters of individuals are assigned to group. So that could be, in the example I have here, you have classrooms within schools. So the classrooms that have students in them are assigned to receive the program or not receive the program. So if units in a study sample are randomly assigned, randomization should create similar groups. Let me give you an example. In this study sample of individuals, we've got people diverse in many ways. Some have purple hats, some have yellow hats, some have red hats. And now we're going to randomly assign some of these individuals to receive the program, and they're in the treatment group, and randomly assign others to not receive the program, they're in the control group. Through this random process, you can see we're evenly balanced now between red hats, purple hats, and yellow hats. So group differences here would be entirely random. And conceptually, what we mean by this is if the groups are the same at baseline, so before anyone has the program, and nothing changes except whether they got the program or not, group differences after the program can be attributed to the intervention. We can say it worked. And with a randomized control trial, you've got to check, theoretically, that the groups are the same at baseline. And that's what we mean by a research design called randomized controlled trial. Briefly, a quasi-experimental design is different. Assignment to treatment versus control is not random. You do have some who have the program and some who don't receive the program, but the researcher is the one determining how that assignment works. It could be that individuals are volunteering for the program and those who don't want the program are in the control group. Could be based on a voucher system. There are many ways the researcher can be the one dictating how individuals get assigned to the program or not. This is an important design that we consider at Blueprints. However, it doesn't meet the gold standard of a randomized controlled trial because there are still concerns with what we call regarding internal validity. And by that, I mean, there are some possibilities that treatment and control groups may not be comparable at baseline. I'm going to talk briefly about an academic paper my colleagues and I from Blueprints published called Common Methodological Problems in Randomized Controlled Trials of Preventive Interventions. And the reason why I'm going to talk about this is because it provides a foundation for why it's not enough to just consider an RCT as the gold standard, which really then introduces the work that we do at Blueprints. So briefly, in this paper, my colleagues and I looked at 851 different randomized controlled trials that had been published between 2010 and 2020, so over a decade of time. And across these nearly 900 RCTs, almost a quarter, 22%, had adequately reported their methods and had no methodological problems, meaning we could trust the causal inferences made through those 22% of the studies that we reviewed. However, in more than half, my colleagues and I saw some sort of design or analysis problem, or we saw that the study was missing information, so we couldn't conclude if we could trust the results of that study. So, what are the most common problems associated with experimental studies or RCTs? What we found is baseline equivalence being a major threat to trusting the study results. Let me explain what that means. We have Group A and Group B. Group A receives some sort of special training and they have a really good result. They have really good positive outcomes. Group B has no special training and their performance is really disorganized. It's undisciplined. Their performance is not stellar. So wow, if your goal is to have great performance through this special training, then maybe your special training is the answer. Everyone should have this special training. Then let's think about this a little bit more. Group A and Group B, and some receive the training and some don't, but then we look at you're comparing a professional football team to a Little League soccer team. Now that's a pretty obvious example being, if they aren't equivalent from the start, you can't say that your intervention made the difference. It could just be that one group was more qualified than another. So that's one common threat to being able to trust a study's finding, if that type of problem exists within a study's design. Another is what we would call differential dropouts. So it's really common when we conduct these studies, what we do is we collect information before the program starts. We call that a pretest. We also collect information on individuals after the program. That's called a post-test. And it's really common that between the pre and post-test, some folks drop out of the study. Could be that they move schools. It could be for many reasons that folks won't complete survey administration from pre to post-test. So what does that mean in terms of understanding differential attrition? Let's assume we're conducting a study and we have two groups, a treatment group and a control group, and we've established baseline equivalence. These groups are the same at the beginning of the program. But then over time, okay, so one group gets the special training, one group doesn't, and our test is basketball performance. And over time, some subjects drop out of Group A from pre-test to post-test. And some drop out of group B from pre-test to post-test. The issue is if different kinds of people drop out. This being another really obvious example, all the short people dropped out from group A, whereas all the tall people dropped out from group B. So the results could have nothing to do with the program. Could just have to do with who you have information on at post-test. So moving on, why am I explaining this to you? What are the takeaways? And how does that relate to your work? Well, first of all of us should scrutinize research. We should never trust something works just because someone says it does. And that scrutiny applies even to randomized controlled trials, which are considered the gold star when it comes to making causal inferences. So that's the first important takeaway. The second is, without this scrutiny, authors could be reporting biased outcomes. Only studies with strong design and analysis quality and a clear description of the method used to evaluate them permit causal inferences. And by improving upon how we design studies, analyze information, and report on results, we actually can improve the usefulness of these evidence-based interventions. However, the good news is you're not the one that needs to figure all of this out. That is exactly the role that we serve at Blueprints and other online registries. Our goal at Blueprints is to provide researchers, communities, policymakers, and agencies with a trusted guide to interventions that work. An analogy we often give is we consider ourselves the consumer reports guides to evidence-based interventions. You can trust us to find interventions with strong research design and analysis so that you can trust those results, similar to how you might trust a consumer reports guide when it comes to buying a refrigerator. I certainly am not an expert in a refrigerator. I'd like to know that someone else has vetted that information and I can trust what they have to say about it before I invest in making such a big purchase. So think about Blueprints similarly when it comes to making these investments in evidence-based interventions. We've done this work for you. So where did we come from? What is our history? Blueprints is actually the longest standing clearinghouse, not only throughout the United States, but internationally. We were started in 1996 by Dr. Delbert Elliott from the University of Colorado. We were the first to establish a clear scientific for evaluating the evidence of an intervention's effectiveness. Our focus initially was on interventions that were effective in addressing violence and drug use outcomes. We expanded our scope more than 10 years ago, however, to include mental health and physical health, self-regulation, and educational achievement and other positive developmental outcomes. And if you're interested in our timeline, you can find that on our website. I briefly want to touch on that several online clearinghouses exist. Even within the department or the US government, there are several federal evidence clearinghouses. And it can cause confusion about which clearinghouse do I go to. One takeaway to consider is that if you find an intervention on one website and it also exists on another, users can actually have, it's like a second opinion, more confidence in interventions rated highly across multiple databases. Even though the number of such programs might be small, investments made in such interventions should pay off in improved outcomes. So briefly, I am now going to tag team with my ADAPT team friends and ask you whether or not you've used Blueprints in your work. And I can see the numbers coming in, and I'm not offended if the answer is no. That's what we're here to educate everyone about. And Patty, Megan, I'm not sure.
Hi there. We have a good number answered, so I'm going to go ahead and end the poll.
All right. So can you see the numbers? I can certainly see them.
I'm going to share the results.
Awesome.
Do you all see them there?
Well, good. It looks like we're definitely skewed towards the majority of you have not used blueprints in your work, but a good quarter of you have. So those of you who have, maybe when we get to the Q&A section, you can talk about your experience. And those that you haven't, or that haven't, I'm hoping that you can get a few useful takeaways from what we have to go through the rest of the presentation, where I'm really going to explain to you how to find information on blueprints. We have a lot of information in our database. Within each intervention that we have certified, we collect information on what the program offers, who it serves, what those activities look like. We collect information on the logic model, the theory. We even go so far as to collect information around costs where available and funding strategy and materials. The point being, it's not enough to say something works, but we want to provide a registry that if there is an intervention that's effective, we want to make sure you have materials you need so that you can implement it with fidelity in your community. So we spend a lot of time collecting information on cost and dissemination as well. The role of blueprints in this process, we started in 1996, as I mentioned previously, with only 10 programs. And as of today, we reviewed over 1,500, and just over 100 of them have been certified, and we have different tiers or ratings within our certification: Model Plus, Model, and Promising. And what I mean by that is 87 of these programs are promising, meaning there's at least one high-quality RCT or 2 high-quality QEDs that have shown that this program works. We consider that moderate research evidence. Promising in that this program has potential in terms of producing desired outcomes. Before it moves, though, to the Model and Model Plus, we need more information. So that's what we mean by moderate research evidence suggested for further testing. Moving then on up to strong research evidence, which are these 13 model programs. These are interventions that have shown replication and sustained effects for at least a year. And then very strong being these 6 Model Plus programs. They've shown replication, sustained effects, and were independently evaluated by individuals not at all affiliated with the development or design of the program. And it's these 2 tiers, Model and Model Plus, that Blueprints recommends for communities to consider in terms of adopting and bringing those interventions to scale. We're constantly asking these questions among the interventions that we're reviewing. Is the evidence strong? Did the intervention have a big impact? Is the intervention ready for distribution? That is the work that we do at Blueprints. And here's how we go about doing this work. We have a whole process for certifying an intervention. We start by saying a report, or we find a report that says a program works. And that report undergoes an internal review by myself and other experts on the Blueprints team. And we have a checklist with lots of questions around research design, statistics, analysis, etc. And we as a team decide if that intervention is designed strongly enough and enough information provided in terms of those results that it should then undergo a second round of review by the Blueprints Advisory Board. And here's a quick snapshot of the individuals from universities around the US, and actually we have some from over in Europe too, who serve on our advisory board. And then throughout this process, interventions are certified as either promising, model, or Model Plus, depending on the type of evidence available. Programs can be excluded from certification at 2 levels, one either by staff or by the Blueprints Advisory Board. I'm not going to go into this matrix of our different rating tiers other than to let you know, beyond Model Plus, Model, and Promising, we also rate interventions inconclusive, meaning we're missing some information, so we can't quite conclude if we can trust the results, to insufficient, meaning there is some sort of design flaw that we really cannot trust those program or the reporting of the program impacts. And there's lots of different considerations we go through in making these conclusions. We look at the design, we look at the effects, whether they're sustained, whether the information has been replicated, etc. What I have for you now is a slide showing we've looked at more, as I mentioned previously, over 1,500 interventions that were reviewed to date. And according to the slide, the majority of them actually fall within the sufficient or inconclusive range of our evidence continuum. And as a result, we won't certify them on blueprints. Here is a screenshot of our website. And on our website, we actually list those that are certified under a tab called Find Programs. Separately, those insufficient and inconclusive get listed separately on a non-certified page so that you can tell the difference in terms of the types of evidence and the conclusions that our staff has drawn in terms of weighing that evidence. There's a lot of information on our website. Here is a URL in terms of how to find programs on our website. We have an interactive search that enables you to identify certified interventions based on specific criteria, and then you can browse through a range of interventions that match those criteria. And what I'm going to go through now is I'm actually going to show you, it's a 7-minute webinar that you can find on our registry as well, on how to navigate our registry, how to conduct these searches. I am going to stop the share briefly because I think I need to click. This is going to be a technical challenge. I'm going to need to click a button so you all can hear this. So give me a moment and thank you for your patience. Hattie, it's not letting me hit the share sound. Technical difficulty.
Are you in the share screen pop-up, Pam?
Oh, here we go. This is why I'm not an IT. Well, let's see. I am. It's just not letting me click on that. It's like frozen. Tell me if you all can hear this. I have a feeling, I'm worried you won't be able to. I'm going to try it now.
Welcome to the Blueprints for Healthy Youth Development website.
Can you hear
We
this?
hear it.
It provides a registry of
We're good, Pam.
interventions that are effective in reducing antisocial behavior and promoting a healthy course of youth development and adult maturity. Though we've been operating since 1996, we recently launched an upgraded website that is more accessible and mobile-friendly. The purpose of this webinar is to help you navigate this updated site and review its functionality. The main goal of the Blueprints website is to help users search for and find interventions that work. While Blueprints staff are constantly scanning the literature for new evaluations on interventions, the site also has a place where individuals can submit evaluation reports for Blueprints to review. And new to this upgraded website is information on interventions Blueprints has reviewed but not certified. These areas of functionality can be accessed most quickly here in the main navigation under Find Programs, Nominate an Intervention, and Non-Certified Programs. But they are also accessible from the homepage via these links. To find a Blueprint certified program, first access the program search area. From here, you can search all of our certified programs or filter your search using the filter tool on the left. Simply expand any filter selection by clicking the plus sign and selecting your criteria. Multiple filters can be applied to your search to fine-tune your results. If you apply several filters, you can produce a null result. Simply remove a selection to detune your filters and improve your search results. You can also perform a keyword search at the bottom of the search tool. However, incorrect spellings and use of keywords not included in our systems will produce null results. You can print results using this button and change the number of results displayed using this dropdown. Additional program information can be accessed by expanding the targets and outcomes selections. And a complete intervention fact sheet can be accessed here. A full description of Blueprint certification process can be found here in the Blueprint certification section. Blueprints has 3 levels of certification. Promising, which includes programs that meet our minimum standards of effectiveness, but require more follow-up research. Model programs, those meet a higher standard, showing replication and sustained results. And Model Plus programs, which meet our highest standard in that replicated and sustained results were demonstrated by evaluators completely independent of the intervention. Blueprints recommends Model and Model Plus programs for large-scale adoption. More detailed information about each certification tier and the requirements needed to achieve each level of certification can be found on the Blueprints Standards page. Remember, items with a plus sign can be expanded to display more information or collapsed to view another element. An overview of our certification process can be found on the Blueprints Review Process page. Our multi-step process ensures that all interventions are up to our rigorous standards and that each program has been reviewed by our staff and advisory board. A new feature on our upgraded website, Blueprints now provides ratings for interventions that have not met our standards in the non-certified programs and reasons for non-certification pages. To access the full list of non-certified interventions and their ratings, click this link. A comprehensive list of all the programs that have not met the Blueprints standards can be accessed here and can be searched by keyword using the keyword search tool. If you have an intervention you would like to submit for consideration, you may do so on the Nominate an Intervention page. The only requirement is that the study describes an intervention that has a treatment and a control group, meaning that some participants receive the intervention and others do not. We do not review case studies, cost analysis studies, or feasibility studies. Evaluations can be nominated for Blueprints review by following the instructions found on this page. Additional information about Blueprints can be found using the main navigation at the top of each page. News and events information, FAQs, and more detailed information about the Blueprints program can be accessed here. If you are interested in information about our conference, please click this link. You can always sign up for our newsletter, contact us, or follow us on social media using the links in the header and the footer. If you have any questions, please contact us at blueprints@colorado.edu. Thank you so much for your interest in Blueprints and our certified interventions. Welcome to the Blueprints for Healthy Youth.
I need just a moment this is going to be tricky again. And during testing, I was messing this up. Thank you everyone for your patience. I think I have this. I'm now going to quickly come in and share the screen again. All right, and hopefully this will work. Here we go. Back to where thank you for that little glitch. One thing I do want to point out that has been updated since that slideshow or the webinar was put together is we do list our promising program separate from our model. You'll see two different tabs listed if you go to the Find Programs page. And also you can now conduct your searches and export your searches to Excel. So just to briefly summarize, we look at evaluations of interventions designed to prevent or reduce negative behavioral outcomes or promote positive youth development. And our focus on youth limits our interventions to those targeting individuals ages 0 to 24. This does, however, include post-secondary education and early employment experiences. And also our aim is on prevention. So the database does not include interventions with the sole focus on evaluating treatment for clinical level mental health problems, including medical or pharmacological interventions. Just to give you a quick snapshot as to the plethora of types of interventions we talk about or we list on our registry. One is the Nurse Family Partnership. It serves youth prenatal through age 2 years. It's a selective prevention program, provides parent training for first-time low-income mothers. Parent Corps is another example of an intervention listed on our website. This is a program targeting preschool age audiences. It's a universal prevention program that provides parent training. Botvin's Life Skills Training Program. It is implemented at the middle school level. It's a universal prevention program that provides teacher and student training. And then Cannabis eCheckup to Go is an example of an early adult intervention targeting the early adult populations. And it is another example of a universal prevention program. I know many individuals here work within the space of alcohol prevention or substance use preventions. This is a screenshot of what it looks like to go on our registry. Click on alcohol. If you do so, you'll get a list of 24 programs that are listed, 6 of which are model, 18 of which are promising. And I am going to briefly introduce you to Megan from the ADAPT team, who's going to talk about a resource that they have provided from the Blueprints Registry that we may have more time to talk about at the Q&A section. Megan? Or Patty? It's like,
It looks
There we
like
go. Am I
we're-
unmuted?
no. Hi,
Can you
Megan.
hear me?
Yes.
Okay, good. Sorry about that, everyone. It was telling me I wasn't allowed to do that, but I got it to work, so that's good. Thank you for introducing me. I am Megan Erickson, and I'm a research analyst with ADAPT. And I just wanted to spend a minute or two real briefly to direct you to our resource supplement and something we've included in there. So really to help support you in identifying effective interventions for your community, the ADAPT team has put together a resource that contains a spreadsheet of substance use prevention programs that we pulled directly from the Blueprints Registry, which is included again in that resource supplement that you should now see on the chat. This list of 19 programs includes all universal prevention programs that target alcohol, illicit substances, marijuana, and/or tobacco as outcomes. The spreadsheet contains key information pulled from Blueprints that can be used as a quick reference to learn more about Model Plus, Model, and promising substance use prevention programs and whether they would be a good match for your community. The information includes the type of program, the setting, the target population, the outcomes found in studies, major components, and program costs and length. Again, that can be found on our resource supplement on page 45, which you should see in the chat. Thank you, and I will pass it back over to Dr. Buckley.
Thank you, Megan. So the last part of this presentation, and we have about 10 minutes left, we're going to focus on what it means to adapt these interventions. Because as we all know, we work in diverse communities who have diverse needs. At Blueprints, I am often posed the question, for whom do the interventions developed in our field work or not work? Many interventions on registries like Blueprints were developed and tested in one population. But now communities are thinking about adopting them with other populations. Should we assume that intervention will not work without adaptation? Or should it be implemented exactly as designed in the new community with high fidelity? Can interventions be transported cross-culturally, there is a debate in the literature on this. One view is that preventive interventions are effective in new cultural contexts only, and I mean only if there is an extensive multi-stage adaptation process and if there's limited, quote, cultural distance between the populations. However, there are some studies, meta-analyses of cross-country transportability that do not necessarily support this claim. Frances Gardner is actually a member of the Blueprints Advisory Board, and she published a paper in 2016 in which she examined 17 studies that transported 4 parenting interventions. 3 of these interventions were originally designed and tested in the United States. The 3 names of these interventions are Incredible Years, Parent-Child Interaction Therapy, and Parent Management Training Organ. And one of these interventions was actually developed and tested in Australia. And the name of that intervention is called Triple P. And what Gardner and colleagues found is these interventions had been implemented in multiple countries: Canada, Iceland, Iran, Ireland, Sweden, Holland, Puerto Rico, Norway, Hong Kong, the United Kingdom, very different countries, and found there really were no differences in outcomes. Gardner and colleagues concluded that there were no differences in effects by country-level policy or resource factors. Contrary to common belief, parenting interventions appeared to be at least as effective when transported into countries that are more different culturally and in service provision than those in which they were developed. Extensive adaptation did not appear necessary for successful transportation of these 4 parenting interventions. Now, that position runs in contrast to different takes in literature about how to consider adaptation. Kenneth Pipe is a linguist who studies cultural anthropology and cross-cultural social sciences, and he developed 2 different definitions that are often used in the EBI literature. One is called an emic approach. And emic being behavior has to be understood in the context of the culture in which it occurs, versus an etic approach in which cultural differences in a behavior can be considered as variations on a common theme. And how that maps to evidence-based interventions is we have examples, emic examples of EBIs. I've listed here the Strong African American Families Program, which is certified as promising on the Blueprints Registry, developed by Brody and McBride Murray. And Strong African American Families Program is for African American families living in rural communities, and it's designed to strengthen relationships and help adolescents develop positive behaviors and respond effectively to the risks of substance use, delinquency, and sexual involvement. This intervention was tested among African American families living in rural communities. It was designed, evaluated, tested within the specific community. A similar approach was taken with Families Unidas, developed by Willie Prada. This is a family-based intervention designed to empower Hispanic immigrant parents to build a strong parent support network and to help their adolescent children respond effectively to the risks of substance use and unsafe sexual behavior. These are emic examples of Blueprint certified programs. I also have for you an etic example. Promoting First Relationships is a Blueprint certified promising program, and it is for workers in home visiting and early care and education settings that's designed to promote healthy relationships between caregivers and young children from birth to 3. It's developed by Monica Oxford and team, and it was validated on a sample of families with an open child welfare case, 77% of parents of whom were white. This intervention was then tested with American Indian families living on a rural reservation. Authors adapted the program to increase cultural relevance based on focus groups with tribal community members and hired members of the tribal community to assist with implementation. And the adaptations to the program included a unique name was created for the program, a study logo by a native artist, longer home visits to include more time for conversation, a small gift for the child at research visits, and a handout about caregiver-child transitions and separations. And there was an RCT conducted that found improved child caregiver outcomes for families in the treatment group compared to the control group for this adapted version of promoting first relationships. So we think about different interventions and whether or not they work. At this point, both EMIC and EDIC strategies are needed when we think about adapting or creating interventions that serve the needs of diverse communities. However, thoughtful and deliberate alteration to the delivery of an intervention to improve its fit must be considered. And if done correctly, it can lead to improved engagement, acceptability, and outcomes. And there's a journal article written by Ballas and company or colleagues published in 2021 that actually gives folks a framework to consider using a stoplight analogy. When it comes to adapting, thinking about green light changes, which could be minor changes to improve reach, receptibility, participation. It could be like what I just went through in the last slide, adaptations made to promoting first relationships in terms of changing name, from given input from community providers or community leaders, how to make these changes, what these updates might look like, versus yellow light changes, where you might be adding or modifying intervention components rather than deleting them. It could include substituting activities, adding activities, etc. These are all yellow light changes that should cause pause in terms of whether or not it could affect outcomes. And then the last stage being red light changes. And those are changes that alter the core components of that intervention, whether it be changing the topic or behavior, deleting core components, cutting dosage, etc. These are the types of changes that should not be made. So we think about briefly, we've got our outcomes, causal antecedents, and that's your conceptual theory. We've got our intervention components, so the activities of our intervention that combined with our causal antecedents make our program or action theory, and this is all what we call an intervention logic model. Researchers, developers, practitioners, well, researchers should stipulate the full logic model of their intervention, and those of us implementing them should make adaptations that are consistent with the logic model. In particular, adaptations that may deal more with intervention delivery. But ultimately, we need to make sure that we are testing any of our adaptations. So I'm going to just touch really quickly on a study we did and published about COVID and how EBIs handled the COVID pandemic in terms of a survey we conducted in May of 2020 and May of 2021, thinking about when the shutdown happened, what did those modifications look like? And we had a 58% response rate for all of our Model Plus, and Promising programs. And what we found is that most evidence-based interventions experienced a small or no impact on delivering their services. And there was a range of modifications to service delivery. And that range was consistent. This was over time. And essentially what we wanted to know is what were these changes looking like? And what we're finding is a lot of modifications to service delivery around telehealth. And it's important to consider that these online delivery changes still need to be tested in order to be ensure that these programs are working. And briefly, I'm going to now end with a study of an example of how different online versions of a training may or may not impact program outcomes. This is a study conducted by Combs and colleagues in 2021 about the Life Skills Training Program, which is a Model Plus program on the Blueprints Registry. And the question was whether teachers trained online had similar levels of fidelity of implementation compared to teachers trained in person for the Botvan LST middle school program, which is in person was the typical way of training. And the outcomes really were identifying fidelity of implementation. I have up here 4 definitions or 4 constructs of fidelity: adherence, whether the program was delivered as prescribed; dosage, whether the program is being delivered as intended in terms of the number of units provided; responsiveness, how well individuals are responding to your intervention; and the quality, how well the program was implemented. And what Combs and colleagues found was that online training was associated with lower ratings of quality of delivery. And there were no significant association between online training or training in person when they looked at adherence, curriculum, dosage, or student responsiveness. So meaning it's impacting some fidelity, but not all constructs. And what does that mean? Well, online training builds competencies important for school-based, evidence-based implementation. However, some of these programs are very interactive, like LST. So in order to ensure the inclusion of experimental learning activities, that might be key to quality of delivery that must be considered with these online trainings for facilitators of school-based EBIs. I'm going to end now as we go into our question and answer section with information alluded to in the online webinar as well, in terms of how you can follow us. If you'd like to learn more about Blueprints, we have a quarterly newsletter. We are on social media, and all of this can be found by going to our homepage. So I want to thank you, and I want to know if anyone has any questions. Is this where you, Laura, pipe in and help facilitate? Okay, you can't talk?
All right, there we go. Can you hear me now?
Yay. Yes.
Yeah, Patty, we'll have to fix that glitch. It doesn't allow us to unmute for a second. Okay, you did have a question come in, Dr. Buckley, and thank you so much for such an informative presentation and detailed and thoughtful in terms of how we could potentially use this information. The question that came in is really related to cost, and we get this question a lot. Implementation cost, cost for the training. Some of the programs have just large package cost, right? I have some ideas that I'd like to share, but I want you to really respond maybe from your lens on how you might address this. The question is, I find most programs being so expensive to implement. How do you go about either getting additional funding to support that implementation process, or maybe selecting a less expensive one overall? How do you think through that?
Yeah, there are several. I'm thinking about this on 3 levels. So the first level being thinking about your investment and thinking about the types of outcomes you're looking to move the needle on. And this is what makes prevention so tricky, because you're preventing problems from occurring. And you've got to think about the lifetime costs if these problems aren't prevented. So by investing in these preventative solutions, you're paying an upfront cost or downstream prevention costs that could actually be quite phenomenal without this type of effective intervention. So really thinking about, rather than in addition to what this costs, what that return on investment might be. At Blueprints, for the interventions that we have listed, included in our package of information we provide, where available, we actually do offer that information up. We provide studies that look at, we don't conduct them ourselves, but we point you in the direction of, given the cost of this intervention, and given the cost if you don't intervene, what is that return on investment? So it does help you think about it in terms of investments. That's one piece. Another important piece, and we didn't talk about this today, but I certainly am getting more and more involved in this. Many states are now going, I know Colorado has just implemented a new policy at the state level where they're requiring agencies to link their request for funding for a certain program or strategy that they want to implement with the evidence to support that strategy. And what we're doing at Blueprints is we're becoming more and more active and involved in this process, because we don't want the agency individual to have to figure out that information. We don't want the budget directors within the state legislatures to have to figure out whether that's good evidence. That's the work that we do. So how do we interject ourselves in that process so that folks know they can turn to us as a resource when it comes to tagging evidence to their choices? So in terms of costs, yes, but I'm finding many of the public funding streams are going in that direction anyway, which is why we want to be useful to help you at least access that information. The last thing I'll say, and this is also tricky, we do our best to keep this updated. We have also looked into funding strategies, whether it's at the state level, whether it's at the federal level, whether it's even looking at foundations, community foundations, etc. What are some strategies you could implement where you work to try and fundraise in order to obtain these types of interventions. So I hope that's helpful, but it's a fair question. And that's why we think about our role is to support you in making decisions about how to invest in preventive interventions.
Thank you, Dr. Buckley. We recently were engaged with a community who made the determination based on the contextual evidence and this idea of, is it acceptable? Is it feasible, right? And is it usable? They ultimately are considering a decision. They do not have funds at this time, or very limited funds. And that's a strong weighted variable in their decision making, but they want to do something now. And so they are exploring maybe even a promising strategy because of the cost variable, but they're weighting it against the research evidence, the best available evidence that's also available. And in their formula, in their community, right, that may be what makes the most sense for them, right? But they are considering all of these things. Two additional resources that I wanted to just mention. WISIP. So on our Prevention Intervention Resource Center, you have a link to that in your resource supplement. We have a list of a variety of different registries, including blueprints, but also including a Washington State registry that can help in different ways. So Blueprints provides a cost benefit variable on their registry, and WISIP will provide even an enhanced version of different types of weighted cost analysis variables that could be considered. Not every program is on the WISIP registry or website. So, there's a caveat to that, but it is a resource. The other one I wanted to mention, I think, was the Prevention Intervention Resource Center itself, and to, just get a good view of what all of the registries are rating, right, a particular program at, so that you've got a nice comprehensive look at it. You understand now in depth how Blueprints grades these things, right, and how they arrive at the recommendation that they do. But we also have other registries listed there, some of which are more accepted, more widely accepted just because they're more known. So we are educating on all of the registries and just get to know them a little bit better and understand where they're coming from and how they arrive at their ratings. That's extremely important.
Laura,
Alright.
can you interject quickly one
Of
comment
course.
about WISIP? So I'm glad you listed WISIP. What we do at Blueprints is for every intervention that's listed as promising model or model plus on our intervention, we then do the research ourselves of whether it's on WISIP. And then we provide that. That's where I mean by an example of a return on investment. So in addition to Laura providing that, if you look within our registry, if that intervention does exist on the WISIP page, then you will find it mapped from we do some directing there.
That's perfect. I love that integration, right? Okay, quick question. How often do you update your website?
Constantly. Our website, every week we have updates in terms of content. So we are constantly scanning the literature, and this process that I described of certification is ongoing. We have 2 advisory boards a year, and it takes that advisory board to come to the final conclusion of whether it meets that intervention meets our standards. But then we go through another whole vetting stage around dissemination readiness. And if we then track down what those costs are, who those developers are, so it's a process. As we find new interventions that meet all of our standards, we then provide updates on our website. And so this review process is constantly going. Updates to our website happen on a weekly basis, but the time it takes to find new interventions is a process, and it does take a substantial time given the amount of vetting that happens.
Okay, thank you. I think we're going to be able to get to all of these questions. There are a handful more that have come in. One that is super salient, though, and very important. We get this one all the time. Life skills. You used a life skills example, right? But the middle school program and implementation of that is the one that's currently rated, right? Correct. Here's the question. Does it only mean that it's valuable and studied and model plus in middle school? Yes. Or can it be implemented in other grade levels with the same effect? How do they think through that?
So it's interesting you say that because I'm actually involved with some of my colleagues at Blueprints on a cluster randomized controlled trial of life skills at the high school level. And it actually is a different program. And the Botvin team from Cornell have identified it as a different, it's very similar. It's just shorter. And given if you think about the risk factors that individuals face at the secondary level, and how those risk factors increase over time through adolescence as they go into the high school level. So they're facing different challenges at these different developmental periods, which is why a new, different version of the life skills training program was developed for the high school level. It has been pilot tested. It was a small pilot test. The results were promising. However, we need that replication and that sustained effect, and before Blueprints can recommend life skills for large scale adoption. So as a person who represents the brand of high quality, standard, rigorous research, design, and evidence to make those causal inferences, I would say that there is a version at the middle school and high school level. If you want results based on what you're seeing at the middle school level, you need to implement the middle school level. It's premature to say if that high school version will meet the same results or demonstrate the same results because it hasn't been tested enough, but a version does exist.
Great, thank you for that response. So we're getting some really nice questions on.
And if I could just then conclude, we will have results of the high school level. It's been pre-registered. It's referenced on the Arnold Ventures website, which is the funder. I want to say, can't remember if it's a year and a half, maybe 2 years before those results won't be made. We're in the middle of conducting it as we speak. Sorry to interrupt.
Okay, no, that's okay. Strengthening families, the Strengthening Families program. So this is a great question. INREP, SAMHSA's old registry, right? It's not being maintained, right? But it's still there. You can still access it. Some of the original EBPs, like Strengthening Families from the early 2000s, are not on Blueprints. Do older programs get removed if the research is not current? He or she is thinking of the Strengthening Families program, in particular for 6 to 11-year-olds, that 14-week program. Can you speak to that? Do they get removed if they're not current? Why? Can you talk about Strengthening Families and Blueprints?
Yeah, I love these questions. These are really good questions. So Strengthening Families actually is on our website as a promising program, the 13 to 14 age group. So not 6 to 7. And I'm not an expert in these individual interventions. I just know the types of evidence we list on our registry. And the challenge with Strengthening Families program, at least age 13, 14, which is on our program, it hasn't been replicating overseas. So there's been a lot of debate, but here in the United States, we do have a study base that was conducted in Iowa that has held up over time. So it is listed as promising. However, to your question about updating, again, everything is multiple levels in these responses. In terms of the scientific evidence, we just went through an update in the last 3-4 years. And what we did is particularly some of these older interventions that have been around for quite a while that have existed on many of these registries, life skills being one of them, Strengthening Families being another. We made sure we weren't missing any evidence. We did a comprehensive literature research. We looked at all those studies. We looked at newer studies to make sure that the science still met our standards. And we actually re-examined some of those old studies that had been published decades ago to make sure they still, because everything evolves. We've gotten better as a research community in terms of understanding how well, or what does it take to conduct a randomized controlled trial? What are those really complicated statistical analyses? We've gotten better at understanding that. And so we went back and reviewed the evidence for these interventions. So that is something that took 3 years to do. There's another whole level around, so that I talked about the scientific evidence. There's another whole level of questions around cultural relevance, examples. And I constantly get questions about, well, this intervention was actually developed in the 80s and it's been tested over the years, but the examples that are in this curriculum don't hold up today, or they're not appropriate. They never were appropriate. And we have this awareness now that this is not okay to have these kinds of examples. And so then the question becomes, what do we do about that? And so that's another whole piece that we're thinking about at Blueprints. How do we unpack cultural relevance? How do you update for culture? We're not the developer, but we can communicate what these efforts have been and what that looks like. And I have to say, that's a direction we're going in. And that is a piece that's of high priority for us. We want to give better answers to those questions we're getting. To date, our responses have been related to some of the slides I went over with you. When we talk about adaptation, it's perfectly appropriate to adapt these examples to make them appropriate for your community. But that does take a lot of work. And so the question then becomes, who does that work fall on?
Thank you, Dr. Buckley. And we are planning on offering a cultural responsive webinar. So a webinar on the various terms, how to think through cultural adaptations, how to think through, even on our end, you know, with our training and technical assistance products, we've thought through how do we make our toolkit, right, on substance use prevention communications, culturally responsive, culturally relevant, right? There are a variety of different terms out there, and how are they defined? What are their distinct differences? So would love to partner with you.
And Laura, I do have some resources for you that we want to then use with our own Blueprints registry as well. So I absolutely would follow up with you on that.
Yeah, actually, there are several organizations that are talking about this at the same time right now. So we'll unite everyone and we'll come together and put together a dynamic next technical webinar on that topic. All right, environmental strategies. Does Blueprints cover environmental strategies as well? Talk about that.
Our focus is on behavioral health interventions, prevention, youth 0 to 25. And to be honest with you, I'm familiar with so many of the other registries out there. A lot of my work is helping folks navigate. I'm not familiar with one that would focus specifically on environmental strategies. It's not to say they don't exist. The world I know is more in the world of behavioral health interventions.
Okay, I'm going to open it up to the ADAPT team real quick. Megan or Patty, any ideas for where this participant might be able to find environmental strategies? And I think we've got the name captured here in the chat, so we can also look at this for you and get back to you via email, if that would be helpful. Patty or Megan, anything?
Nothing's coming to the forefront of my mind, but in reviewing our various lists on the website, we'll take a look at that and see if we can find a close fit.
Okay, great. Thank you. Okay. So I'm going to combine a couple questions here. We've got 6 minutes left. So in conversations that I have attended, they have advised to conduct small groups to see if the program is actually viable in the communities, right? So viable, we might be able to break down to by the contextual evidence definition, right? So is it feasible, acceptable, usable in the community? Focus groups or these small groups are being encouraged to be conducted. So they want your thoughts on that. Concurrent with that, and underneath this umbrella of engaging communities, do you have any webinars on how to draw out creative ideas, draw out community engagement and key stakeholders and partnerships to implement and rally around a Model Plus program? So, two-part question.
Exactly. I'm not sure if I fully understand the first question, so I'm going to start with the second and let me know if I'm not answering folks, if I'm not making sense or not meeting your need. There are frameworks that exist to help with community buy-in and to make sure that whatever approach you're taking fits with the need of the community. So that and these different approaches, some of them are listed on our registry. And there's a newsletter I wrote about this very topic that I will make sure Laura and Patty and Megan have access to, because it gives other examples. One that pops to mind is called Communities That Care. I don't know if folks are familiar with this model, and it's a whole process where you engage folks from different levels, community organizations. It could even be public officials, elected officials, teachers, individuals that live within the community, and they do an assessment about what the needs are, what the risk factors are they're facing, what the protective factors are. And then they go to the Blueprints registry and they do a search based on those risk and protective factors, because that's some of the search criteria that we offer. And then they see the inventory of interventions that show up, and then they'll have a discussion as a group about whether, okay, is it a school-based approach, a home-based intervention? What is the need that would fit best with this community? And the group unpacks all that, given that list that they're looking at. And then there's a whole process around budgeting and a whole process around engaging and fundraising and sustaining. That's an example of a model to help, where Blueprints is a resource to provide an inventory of ideas for implementation based on the needs of the community. Prosper is another model. Prosper is very similar to Communities That Care. It's also listed on the Blueprints registry. However, it involves a university as one of the partnerships to help serve as a liaison and engaging the community. So those are just two quick examples I can offer you in terms of frameworks, and I will follow up with Laura and Patty with other examples.
That's great. And anything that Dr. Buckley sends us, we'll disseminate to all of the participants in today's webinar. I think the first question was really geared towards, do you encourage, or what are your thoughts on conducting focus groups and small groups to get ideas and just some understanding of if a Model Plus program could be viable in that community?
I think that's an important and scaled down example of what I just provided with Communities That Care. The point being, we all know nothing is going to be effective if it's being forced upon individuals. So we really do need to get input from those that we're looking to share these strategies with. And there are different leaders within who that might look like. So a focus group is one tool you can use, one mechanism in order to gather input about what types of challenges are being faced by certain communities.
Okay.
And what some of these strategies might look like and how they might be perceived by individuals within that community.
Okay, great. I know that Patty is going to have some last minute things to share with everyone about the evaluation. Going to end on two things, just a comment from a participant about considering adding programs for youth related to problem gambling prevention, since there's been a huge expansion of that. So just a consideration for you to take back with you. And then
And if you see those studies, send them our way.
So, yep, and the video nicely demonstrated how to do that. The final thing I want to end on was actually one of the first questions that came in, so I apologize to this person. Do you have a list of gold star ordinances that communities can use? Gold star ordinances.
I'm sorry, I don't understand the question.
Okay, I wonder if that individual was referring to best practices. And I think we've covered that in depth, but that's not, that particular phrase is not ringing a bell. All right, and then we've got a slew of thank yous. So I'm going to thank you, Dr. Buckley, and I want to thank the ADAPT team. And most importantly, I want to thank all of you for coming to develop your skills to increase your knowledge on this particular topic. At this point, I'm going to hand it over to Patty. Thanks everyone for attending.
Thank you, Dr. Buckley. Thank you everyone for being here with us. We just ask that you take 1 to 2 minutes to please let us know how we did today and how we can help you in your prevention work moving forward. That opportunity is going to pop up as soon as we end this webinar. It just takes 1 to 2 minutes. For those who want CEs, you will be required to complete that and indicate where you'd like us to send your CE certificate. You can expect a follow-up email with all the resources we shared by early next week. And on behalf of the ADAPT team and our presenter, thank you for joining us and have a great rest of your day. Take care, everyone.
Bye-bye.